Okay, good afternoon everybody, and welcome to the November meeting of the Warrington Health and Wellbeing Board. Everybody's very welcome to this meeting. Stephen Broomhead, the Chief Executive who normally chairs this meeting, has been unavoidably delayed, but I'm sure as soon as he has joined us, he can take over in the chair. But in the meantime, I'll get things started. So, as I say, welcome everyone. Do we have a list of apologies, please?
Yes, we do. Thanks, Councillor. We have apologies from Councillor Paul Warburton, Sarah Raj, Colin Scales, Simon Constable, Dr. Andrew Davis, and David Cooper. If there are any further apologies, please forward them to me. Thank you.
Sorry, Jenny. Did you say Tara Raj?
Yes.
Sorry. Yeah.
Okay, thank you. Then in that case, we'll move on to the second item, which is the Code of Conduct. Does anybody have a declaration of interest that they need to make apparent? If so, now's the moment. I'll take silence as being the fact that there are no declarations. So if we just turn to the minutes of the previous meeting, we're in quite a fast-moving territory at the moment. So if there are items that perhaps are going to come up on the updates from partners, we don't need to particularly go into them at this stage. But if I take those minutes page by page, is there anything? There won't be anything from the first page, the second page, the third page refers to the Warrington Together report. Anything on there?
No.
That sort of continues over onto the fourth and fifth page of it. Without being confusing, if we then go over onto, I think what's page 6 of the minutes, which is page 10 in the papers. Again, it's situational awareness, so it's all about the very current information, which I think we'll come to later in the agenda. Anything on there or on what's numbered page 11 in the papers? No. And again, not to make too heavy weather of it, page 12 or 13, anything that comes from there? No. 14 or 15? And 16. I'm going to take silence as nothing to add. So if we go straight into agenda item 5, which is the newly updated Children and Young People Health and Wellbeing Profile. So if I could invite that report to start, please.
Hello, it's Janet here. Janet Ubido from. If you can't hear me, just shout. Give me a shout. I'm phoning in. Janet Ubido from the John Moores University Public Health Institute. We're an organisation funded by CHAMPS, the Cheshire Merseyside Public Health Intelligence Unit for Cheshire Merseyside, and we've been asked to provide profiles, an update to the 2017 profile that we did for children and young people. With the aim of informing planning and to provide this current one will hopefully be used to help assess the impacts of COVID, use it as a baseline for see how things go in the next few years. So to start with, the population aged 0 to 24 in Warrington is about 59,170, which is about 28% of the total population, which is more than Cheshire East and Cheshire West proportions, but less than nationally. And 7,692 of those children are from ethnic minorities, which is 13.3%, which is more than the other authorities in Cheshire and Warrington, but less than nationally, which nationally the figure is 33% of children are ethnic minority group. Music playing there. The deprivation. There are significantly lower levels of deprivation in Warrington and significantly lower levels of child poverty compared to the national average. child poverty levels are actually the second lowest in the whole of the North West, although deprivation levels are higher in Warrington than in the rest of Cheshire and Warrington. Levels of lone parent families are quite high, and looked after children higher than the national average. Rates of hospital admissions for asthma amongst children and young people are significantly lower than England, and they are actually the lowest across the whole of the North West. However, rates of admissions caused by unintentional and deliberate injuries for children and young people are significantly high, also significantly high in the rest of Cheshire and Warrington. That's for ages 0 to 14. So looking at different age groups now, that pre-birth and early years, there's significantly fewer women smoke during pregnancy in Warrington, which is the second lowest level in the Northwest, 8.1%. We've not included in the chart infant mortality and low birth rate, but they're similar to the national average. And there's significantly high vaccination uptake rates, the same across the whole of Cheshire and Warrington, very high. But significantly fewer babies are breastfed, only 39% after 6 to 8 weeks. And admission rates, hospital admission rates for babies are significantly high. The highest in the Northwest. Warrington has the highest in the Northwest, with the rate 2.5 times as high as the national average. There's 206 per thousand in Warrington compared to 77 per thousand nationally. But childhood injuries, admissions for childhood injuries, ages 0 to 4 in the early years, they're similar to the England rate. Even though in the rest of Cheshire and Warrington, Cheshire East and Cheshire West and Chester have significantly higher rates, but in Warrington they're similar. The injuries for 0 to 4, childhood injuries or intentional or deliberate admissions. Right, moving on to primary school, in Warrington there's better levels of school readiness than nationally. It's the second best in the Northwest, 73.6% children considered school ready, a good level of school readiness. And Warrington is the best in the Northwest on school readiness for those with free school meals, which is 61%, similar to the national average, but it's best in the Northwest. Levels of obesity in children are similar to the national average, and they are amongst the lowest in the whole of the Northwest. But nevertheless, it's still a cause for concern because national levels are so high. So even though we're similar to national levels, it's still high. Around 1 in 10 for ages 4 to 5, and 1 in 5 ages 10 to 11 are obese. In Warrington has the 4th lowest levels in the whole of the Northwest for children with decayed or missing teeth. But this is still high. It's about a quarter of children primary school age have decayed or missing teeth, so it's still quite high, even though it's low compared to the rest of the Northwest. Moving on to secondary school ages and young adults. Average educational attainment is significantly high. That's 49% with 5 or more GCSEs, which is the 3rd highest in the Northwest. There are significantly low rates of first-time entrance to the youth justice system, which is the lowest in the Northwest. Chlamydia detection, however, is low in Warrington, and there are significantly high rates of hospital admissions for young people with unintentional and deliberate injuries, and also admissions for self-harm and alcohol and substance misuse are all significantly high compared to England. And we haven't got this on the summary chart, but there are significantly high proportions of child and young carers at a lower level of care. So it's a lot of young children and young people, but nevertheless that data is quite old. It's from 2011. So that's a summary. That's a brief summary of what's in the report. The report's got more indicators, but we just selected all the main ones that we could find for each age group. Okay, and that's it. That's me done now. Hello?
Els, you're on mute.
Sorry. Thank you very much for that, Janet. Have we got any questions?
Yes, Rebecca, could I ask something? It's Matt Smith.
Absolutely, go ahead.
Thank you. There's clearly a lot of positives in the report. I'm not actually really going to focus on those. I'll look at some of the negatives as well, and there are some concerns in there, I think.
Yeah.
Particularly around the hospital admissions that is at the bottom right of the slide you showed there, with the injuries, self-harm, alcohol and substance misuse. These are obviously complex issues, potentially some links there to mental health, which is, you know, a big and relevant issue with young people at the moment as well. I noticed that the data on there is, depending which one we look at, is 2016, 17, 2018, 19. No idea about the pattern and how that's evolving over time. So I wondered if you had any idea about how that might be changing over time, or what more recent data might be suggesting. And given the challenges, you know, the concerns that you'd have around those, and particularly there was one more that I thought, the hospital admission rate for babies, which was particularly high. I'm sure people in the meeting could tell us all sorts of positive things that are going on and work we're doing to help with all of these, but there's clearly still some work to do there with our partners. So I wonder if it's something worth revisiting perhaps at some point in the future. Thank you.
Yeah, the hospital admissions data, it's for the injuries, it's all, we've presented all the latest data that was available at the time. 2018 to 19 was the admissions for injuries for young people, children, you know, the teenagers. But yeah, I'm not sure what the trends are in that. We could look into that. It is available. If anybody wants to look at the PH, if you just Google PHE fingertips and type in a search keyword like what you're interested in, you can get a nice little chart and there's a column at the top for trends, so you can look at the trends for each of these. But I haven't got the information to hand.
No problem, thank you.
Yes.
Any more questions for Janet?
Yes, please, Chairman.
Go ahead, Ian.
Yes, so this is a bit of constructive criticism. That it's nice to see a colour chart on the screen at the moment. I must admit, I did find it very hard work reading this paper, because if it's in black and white, trying to sort of work out what the colours mean is quite a difficult thing to do. Now, I'm not suggesting we should have colour prints, because I know that costs too much. But whether when people are preparing reports like this, they can just bearing in mind that for those of us who are going to see it in black and white, if there's any way they can do a presentation which is a little bit clearer and easier to read. And secondly, I mean, obviously an awful lot of work has gone into this. I just felt that what was perhaps sort of slightly lacking, and perhaps the last questioner hinted at this, is some sort of what sort of actions we should be doing, what's really important from all these trends, you know, what we should be doing about it. I know this perhaps comes up at other times, but I think it would just been useful to have seen this at the end, so we could concentrate on those things, particularly those things that Warrington's not particularly good at. Okay, thank you.
Right, yeah, thank you for that. Yeah, we do try and look at the black and white friendly reports usually, but when it's this kind of rag rating, you know, maybe we could try and find shades of red and green that are a bit more different when they're in black and white. Yeah, good point taken though. Yeah, and the actions, yeah, are very important. But a lot of our reports we do look at the actions. But this one we were just particularly asked to just provide a profile, so the actions to follow from discussions, you know.
Councillor Knowles, could I come in? It's Amanda Amesbury, Director of Children's Social Care.
Of course.
So I think that Janet's absolutely right, and it's a good question, Councillor Marks. The next steps for this from me are for us to actually take this into the Early Help Partnership Board and the Warrington Safeguarding Children Board, for us to commission through those groups some additional work to look at how we improve on some of the areas, and improve on some of the areas where we're doing well, of course, but also what we need to do to inform what we're commissioning or what services we're providing and what interventions we can provide around the rest, and to drill underneath particularly those hospital admission rates. I always get a bit confused, and I did again when I read this, between deliberate and unintentional. Actually, it just means that any hospital admission, doesn't it, ultimately? So we need to get underneath that and have a look at those as well. There was a theme running throughout the report for me around mental health, linking in with the alcohol misuse as children get into the older years, etc. So I think there's some work for us to do there as well. And Janet, I just wondered if you could clarify chlamydia detection rates is that bad because then loads of children go on and get chlamydia, or aren't they then, or what does that mean, low detection rates? Because low detection rates could mean they're not getting it.
Well, that's true. Yeah, yeah, that's true.
Because if they're not getting it and it's not being detected, it's not a problem. But if it's been detected too late, then that's a significant problem for young girls in future lives.
Yeah. Yeah, they're considering low detection as bad in this report, the Public Health England data. So, yeah, I suppose it all depends, doesn't it? Really, yeah.
So I suppose we can ask questions of our health colleagues through the Warrington Safeguarding Partnership if this meeting agrees that we take that there as a next step, and we can do some work underneath that around commissioning, and as I say, Paula through the Early Help Partnership Board as well.
Yeah.
Please, could I comment as well? It's Lucy Gardner from Warrington and Holton Hospitals. So thanks, Amanda, completely agree, and very happy to work with you on the next steps. So I think there's some elements that are already being picked up in terms of our respective strategies, in terms of actions, and I had a really useful conversation with Marianne Hunter yesterday around ensuring that the primary care strategy and our strategy from a hospital perspective are aligned in terms of the actions that are needed to address the issues that we have and the health needs that we have locally. So we'll continue to do that. I also think there might be an opportunity through the Town Deal programme to address some of these specifics. It would be really helpful, Janet, if it's possible to share this report outside of the pack so that we can use it in a number of different forums going forwards.
Yeah, I mean, that's fine to circulate it, yeah.
Great, thank you.
Councillor Knowles, can I come in there as well? It's Sarah Quinn from Bridgewater. I can only echo Lucy's comments as well, and obviously as a provider of community services in the 0 to 19 service, I found this report really helpful, and it just informs us on areas that we can work together to strengthen the work that's in this report and the progress that's needed from that perspective. So keen that Bridgewater are connected with the hospital and with the Borough Council services from that perspective.
So I think if I could sum up there, I think there's a collective will, and that's indicated by the number of people who've just contributed to the discussion afterwards. There's a sort of collective intention to look behind this information and work out what those themes are, and most importantly to get some actions against some of these items. And I suppose the thing that stood out looking at this myself was some of the things that sort of stand out a little bit against some of the other trends. So, we're doing very, very well on outcomes and school readiness and all of those sort of things. But why is the breastfeeding an outlier? We're doing pretty well on the tooth decay, not to be complacent about it at all because it's still high, but as against national, and that fits in with the obesity part. But again, do we link that back to something that's not quite going right on breastfeeding and that very early support around new mothers? So there are lots of other links that we can pick up there and get some real sort of good thinking going around. So I think that's really, really helpful. So I think Amanda's action, and I'm looking to you for a nod here, is that it goes to those two boards for some much further detailed work. I've got a thumbs up as well, so that that's where the actual hard work and partnership working is going to go on to turn this into something that will actually improve things for our children and young people. Does that seem like a fair summary of where we're at with it? But very, very useful information, and a lot of things that are very encouraging about Warrington, which do make a difference to people's life chances over the whole life course, particularly some of the stuff around educational outcomes. That is massive, isn't it, for the rest of people's lives and their economic advantages and all sorts of other things. And it helps to break the cycle of deprivation, doesn't it? Which is what we have to look forward to in the long term. So is there anything else on that report, or shall we move on to the next agenda item? I've also had a text from Professor Broomhead just to confirm that he is bedevilled with IT issues and would I chair the meeting, so I'll do my best. I think there's a difference between coming to a meeting to participate and coming to a meeting to chair it, so do bear with me. So the next item is the update from the reference groups, and the first of those is the Integrated Commissioning and Transformation Board update, which is CAFS.
Hello, Chair, it's Carl Marsh. I've dialed in. Kath and I are co-chairs of the Integrated Commissioning and Transformation Board, so we share it. We actually arm wrestle who's going to present, and Kath won again, as she sometimes does. So if I could take us through and then hand over to Kath at the end, who wants to talk a little bit about integrated care teams. So
you danced a beautiful duet as a double act, you two. Carry on.
Absolutely, choreographed to the nth degree, Chair. If I could remind everyone what Integrated Commissioning and Transformation Board, which I'll call the board or ICTB, is responsible for overseeing joint commissioning across the National Health Services in Warrington and the local authority, and is designed to support whole system transformation. And one of the key tasks of the board is to ensure the optimal use of collective resources, such as the Better Care Fund, the Improved Better Care Fund, the pilot funding that we've had for rapid community response services, and just to make sure that we optimise the use of that. And one of the things that we do is we try to have a main effort to make sure that we are stitched into the system. Kath calls these the big ticket items, and they are about keeping people healthy at home and also supporting discharge where appropriate. And what I'm going to do, Chair, is just quickly outline some of the key decisions that we've made in the last reporting period since the last Health and Wellbeing Board. And one of the first things is we consider a request for the Good Neighbour voluntary scheme. And schemes like this are local voluntary schemes, and they offer temporary support to those who may need it. Such groups might be those living with frailty, those living with disability, etc. One of the key things that we found in the last 6 months is the impact of COVID-19 has had on some people struggling to reconnect with the world, and services like this are fundamental in supporting that. These schemes do not replace what is already out there in terms of work done by social services and other care agencies. They complement it, and the scheme was approved by the board. We also looked at a British Red Cross scheme. We currently, through the Improved Better Care Fund, we have a contract between the council and the British Red Cross. That was due to expire in September, and what it provides is a provision of support of an at-home service. We were hoping during this year to relocate that with the rapid response team, because they are complementary services and would support one another, but that's not been possible during COVID-19. And instead, the services supported individuals through increased use of telephone contacts, risk-assessed practical support where discharges occur. So once again, supporting that approach around the big ticket items of supporting people when they're discharged from acute services. And that scheme too was approved by the board. What we also, in terms of our main effort in the big ticket items, we've been looking at schemes and individual services that we can support using what's called the discharge to assess funding. And there's new guidance that sets out additional funding from the NHS that can be used to support discharge. And we looked at 2 schemes that can draw on that funding to support discharge from acute services into community settings. And one of the things I think that Kath and I have been struck by is that we've gone from idea to approved business case in about 3 to 4 weeks. I'm not sure pre-COVID we would do it that quickly, and I think this is something that we definitely need to retain beyond COVID-19, whatever that looks like, in terms of being able to get system partners round the table and move things on really, really quickly. So trying to do enhanced discharge has been challenging in the current climate, but we've been doing it nonetheless. One of the schemes we looked at was additional transitional beds, increasing the number of those in a community setting. And these are additional beds that support discharge, the discharge to assess policy. And they are nursing beds for people that require 24 hours nursing care. And quite a significant number of those, which was approved by the board. We also looked at, so that's for individual cases, so that's beds. We also looked at discharge to assess schemes, and the Better Care Fund with stakeholders from the system had a workshop to look at what are the things we can do to utilise the Improved Better Care Fund funding and the discharge to assess National Health Service funding that will support discharge, and in terms of supporting the assessment discharge to assess the patient rather than assessing it in hospital. And the key principle that we were looking at when we looked at those business cases, both at the BCF and at the board, was the principle to return people to homes quickly and as safely as possible. So the proposal provides the three key elements: support assessment within the hospital, assessment capacity in the community, and also to provide care and therapy capacity in the community. So it's more about services than beds, as was the transitional bed model. And both those schemes were approved by the board. The board approved the Improved Better Care Fund element and endorsed the discharge to assess element to the NHS, and the NHS approved the use of that funding in the case of our discharge to assess scheme. And if I can quickly just go through some other highlights, I won't get into the detail of these. We have the programme manager for the review into our intermediate care services presented on where we were up to in terms of the modelling and also the key design principles of that review, such as Home First and better integration. They were approved by the board and probably ready, notwithstanding a few tweaks, to go to consultation. We also looked at the Warrington and Holton winter plan. We look at that every year. We are not asked to approve that, but we're asked to provide comments and basically to do a critical friend role, which is really, really helpful. Those comments were received. That was submitted to the NHS regulators, NHSE, NHSI, and the winter plan for Warrington and Holton system was approved by NHSE with very little conditions in it as well. And those conditions that were in there were addressed fairly quickly. And we also reviewed the progress of the Warrington care record, and we provided comments and support, and have asked the programme director to keep the board updated. And I think they are the key points from me, Chair, but I wonder if I could just ask Kath to give us an update on the work we've been doing across the system around integrated care teams.
Hi, thanks for that, Carl. I think there were just a couple of points I was going to make on the back of the update Carl's given. One was around the fact that we have established a group under ICTB to take forward the work that we went through for 6 months with the Design Council last year and the LGA, which is very much around living well in communities and making sure that real early intervention and prevention work and place-based work with our communities and our third sector partners, that we really start to bed that in, because that needs to underpin and work across all the work streams that we've got underway at the moment. So that group has been established and is reporting into ICTB. as part of that, we've also commissioned, and I think most of the members of the Health and Wellbeing Board will have received an invite for a festival that is run by the National Development Team for Inclusion. They are the organisation who are going to support Warrington to deliver community-led support over the next 18 months. The festival is currently underway from the 9th to the 18th of November, and basically community-led support has been adopted nationally across the country by 20+ systems, and it's very much about how we connect to our communities, how we have different conversations, how it's very much led by the community, where we engage with people in the communities so that we can support people to live quality lives. So we've just begun on this journey. The festival is happening now. There's a whole series of events that members can log into to hear more about that work. And the plan is that we will begin in earnest with an innovation site in the spring of 2021. That very much links to the work that we had started and around the development of integrated community teams on a place-based footing. Obviously with COVID striking and people having to work from home, that did stop some of the actual working together in terms of co-location because of the need for us to work safely. However, that work has continued remotely, if you like, and it's linked in very closely with the work of the development programme. It's linked in with the frailty programme. So there are 5 products. There's a work stream still continuing to work remotely on the development of the integrated community teams, and they're working on 5 products, so that they're really honing down now on the cohort of people within the community we're going to work on, the assessment tool, a virtual caseload, mapping the patient journey, and developing guidance on sharing caseloads as we come together as health and social care colleagues. So it was just to update really on those specific links. Thank you.
Thank you very much to Carl and Kath there. Do we have questions or observations, comments for them? There's quite a lot of silence there, and also don't want to disinclude anybody who's dialed in on that. If you have, you can't really indicate, but just speak up.
Can I just ask, I spoke to Tara, Director of Public Health today, about the, was it the neighbourhood workers? Who's delivering that? That would be helpful to know.
I don't know whether you want to come in there, Carl, or...
Do you know what, I was going to say the same thing, Kath. I think you might be closer to the detail, and if between us we don't, we can get that to members ASAP.
Basically, we've linked in with the third sector on that. I'm not very close to the detail, but it's not there to replace the assessed work. This has been a programme based on the fact, this has been an initiative based on the fact that we know there's been a significant impact of COVID on carers and on people who are living, who are even more isolated in their lives. So the Good Neighbours scheme, we've been working closely with the third sector to look at how we can support some of the existing mechanisms which already exist, and that group of volunteers who were harnessed in wave 1 of COVID, to make sure that we can consolidate and really reach out to people who may be really struggling. We can come back with more detail if Health and Wellbeing Board would like that.
Well, I don't doubt the merit of that, but I wonder, Steve, are you aware that Warrington Voluntary Action have been commissioned to deliver that work systematically?
Was that a question for Steve Cullen?
Sorry, Steve Cullen.
Have we got Steve Cullen on the call?
He was on the call. Okay.
My understanding was that they are very much involved with that, okay. as they were with the Safe and Well offer in wave 1 of COVID.
Okay, that's
linked
great.
in with the neighbourhood team.
Yeah, it was just topical, Chair, because Director of Public Health asked me about harnessing the good work of the voluntary agency, so it's good to see that that's happening.
Yes, I think Alison and Steve Cullen, you know, it's been very much about building on the fantastic work that was done by our voluntary sector in wave 1. I haven't got the absolute details of that because it's very much a work in progress, but we can come back with that. But I know that it's been absolutely about building on what we've already developed.
Just to add to that, Councillor Nels, Eleanor Blackburn had indicated in a different meeting that there were at least 100 volunteers already lined up through the third sector to support us with this programme.
More than that.
Yeah. I think the power of volunteers has been really proven, hasn't it, in the earlier stages of COVID, and there were lots of encouragements for people to sign up and so on. But I think that the challenge is to make sure that it's the right sort of volunteers and that they're able to offer the right kind of support, and that's where that kind of coordination has been really, really valuable. But it's a pilot study, and I think the learning from that has potential to be applied over the longer term in really, really useful ways, particularly as we move to a more sort of community-based approach to doing things as a sort of general philosophy. Yes, Simon.
Chair, it's Carl Marsh again. I've just quickly reminded myself of the business case, and there is a project board which includes Adult Social Care, Clinical Commissioning Group, Public Health, and the Lead Commissioner for WVA. But we can share this as well.
I think Councillor Knowles is frozen.
Hey, it's Jenny from Democratic Services. I think Councillor Knowles has just dropped off the call. We'll try and bring her back in.
Okay, do you want me to go on to 6B then, Jenny?
Yes, you can do if you're happy to do so, Simon. Thank you.
Thanks very much. Just a verbal update in relation to Warrington Together, which, as you know, is a system-wide programme around collaborative population health support. A few items just to update you on. I won't repeat what Kath talked about in relation to integrated community teams, but we're taking forward Dr. Andy Davies' paper, which was presented to the last Health and Wellbeing Board in relation to a more collaborative approach to commissioning and provision. So that's on a ongoing basis, and it's being considered by the revised Provider Alliance, which meets on Monday to look at various issues, including ICTs. So I won't talk about ICTs. I'll still Lydia's thunder in relation to the People's Panel, which has been really effective in relation to communication, particularly around COVID, Had a couple of reports about mental health issues and young people in transition age, particularly around those aged 14 to 16 are not getting their mental health assessed or visiting GPs, as they do not want their parents being informed. There is a particular issue around young people who are 14 or older who have full mental capacity around parental involvement. But I'll let Lydia expand on that if I may. They also did a report around flu jabs and around acknowledging that struggling to access a jab could cause anxiety. Just wanted to big up the Disability Awareness Day, which happened on the 25th of October. We all had stands, I think, which was very helpful. And on the 27th of October, we held a virtual workshop as part of Dad Week, talking about integrated community teams and frailty. There was a particular issue that was raised, which we couldn't answer at the time, about making sure that consultation around changes to provision of care takes into account accessibility to transport. People probably have been aware of a new organisation in Warrington which has been very successful, called Movement, which talks about tackling suicide, particularly amongst men. And there was a event and a series of social media publications around making sure that Movement connects with the whole of the issues across Warrington, which included the Darkness into Light walk, which happened on the 9th of September, which we were involved in, which was a 2 AM walk from Widnes Viking Stadium to the Halliwell Jones Stadium to try and prevent the number of people who commit suicide in Warrington on a yearly basis, to increase awareness and to encourage people to talk. We had a meeting around specialist housing with members to talk about how we can ensure that housing associations have a pipeline of developments in Warrington which have been dictated to by commissioning. So that was a very successful meeting, and I wanted to emphasise to members about the work that all members of Warrington together have been involved in as part of the successful £22.5 million town centre deal, which at last starts to connect health and wellbeing issues with other issues such as transport and regeneration. So there's a real opportunity there to look at how wellbeing can be embedded within the town. Just to thank you to the hospital, particularly Lucy, in relation to a bid we put forward to the Health Foundation bid around innovation, again promoted by a partnership approach, and the bid we should know by January whether we're successful, but that emphasised our links with academic institutions and University of Chester. And we're planning with the voluntary sector to, once COVID is out the way, to have a celebration of our very rich voluntary sector, particularly the programmes that the council support with the voluntary sector, like My Life Warrington, to encourage people to celebrate and invest in our local voluntary sector. Chair, I hope that's helpful if you can hear me, and then but I'm happy to take any questions.
I'm sorry that I've been bedeviled with tech issues as well, but I am back in now properly. Thanks for the report. And yes, does anybody have any questions?
Chair, I'd like to add to that, please. Lydia Thompson from Health Watch Warrington.
Thank you.
Simon, thank you. Yes, just to add to that, Health Watch Warrington published our young people's mental health report and also the COVID survey update report. And we are meeting with representatives from CCG actually today to discuss all the recommendations from Healthwatch Warrington. And we look forward to updating you with the information from that meeting.
That's useful, Lydia. Thank you very much. Anyone else with any observations, comments, questions?
Councillor Knowles, can I come in there? It's Sarah Quinn from Bridgewater. Just to say, really to echo both Kath and Simon's thoughts around the ICTs and the progress that we're being able to make in terms of those work streams. We've been supported by Alex Robertson, the Director of the Frailty Programme, and we seem to be making some really good progress and hope that will continue over the months ahead.
I can certainly vouch for that, having sort of slotted into some of those sessions where, just to get a bit of a snapshot, I appreciate it's operational, but it's good to be able to see what's going on, and that, you know, there's a lot of pace and a lot of thinking going on in there, isn't there? Getting a nod from Sarah on that. Yeah,
definitely, and I think there's a lot of goodwill from all the partners in the system to really push this forward, and that it's the right thing to do.
Absolutely. So I think if we move on to the next item, which is item 7, which is if we don't have any more comments on that item, or from anybody who's dialing in, should we go on, Simon?
Thank you very much, Chair. I appreciate Carl's and Lucy's take on this. Professor Broomhead, MBE, asked me to develop this report initially as a learning for the management team of the Cheshire Merseyside Health and Care Partnership. So thanks to Sarah Garrett for producing this. I've just padded it out really. So hopefully people are aware that Warrington was a pilot site in relation to 111, with the intention of, if it was successful, to be rolled out across the country next month. It was in part a response to COVID, to stop infection within hospital, to stop congestion within emergency department waiting rooms, and that to ensure that patients follow the best care pathway possible. So at 3, Sarah's very kindly put forward the project and governance arrangements, which I think were robust, and then on giving those arrangements to NHSE, and I went live in 8th of September. It's very early to give any evaluation, but I took it upon myself, given Professor Broomhead's instructions, to talk to Healthwatch and to all members, and it seems to be well received. The only drawback I hear was around the ability to get through to 111. So I'm sorry, that's a very rudimentary run through around the 111. It's important that we are aware of this, given that we're a pilot scheme, but I'd be very grateful if Lucy and or Carl can give any more information about or more topical information about how it's been received locally. I hope that's helpful.
Thank you, Simon. I think that's a good read across. Just a couple of points from me, Chair. Firstly, on the opening sentence, and I know this is just a thing of language, but it's probably important, it is that patients are encouraged, that they are not directed or told, they are encouraged to use the NHS Treble 1 first service where they get a booked appointment. And the key thing about that is a timed appointment helps us prevent overcrowding in ED. And the other thing is that it's, and this is a language thing again, I think, but it is not a pilot scheme. This is how we will use NHS Treble 1 moving forward. and what we are doing is we are an early mover. And you're absolutely right, Simon, when we were approved by NHS England after our prep, we were approved without any conditions. And one of the key things that the system project team are doing is working with other sites as far away as Frimley and as close as Wiston, in terms of, what are the difficulties, what are the challenges. And one of the challenges has been, that you've rightly pointed out, is the pressure on NHS Treble 1. So we have not been able to communicate this in the way we would like, because of concerns about destabilising the NHS Treble 1 service. To ameliorate the pressures on the service, they've been in escalation and have been receiving mutual aid. So an additional 30% of calls being handled. That ends today. So we'll be watching to make sure that there are no issues in the volumes of calls being picked up. And if there are, we have a really good stovepipe into the national team, and we will escalate it. That's all I wanted to add, Chair.
That's very helpful. What about Lucy from the hospital's perspective?
Thank you. So I think it's been well received. I think the uptake is not very high at the moment. So hopefully we will see that increase. It might be helpful just to share with you our kind of pattern in terms of A&E attendances, because we had seen that actually they were very similar to the same time last year, which wasn't the case during the first peak of COVID. And actually we are now just starting to see them come down again, which from a kind of hospital capacity perspective is helpful. And we obviously hope that it's those patients that don't need to access A&E that are now not coming. In terms of the uptake of the NHS 111 first, I think it's about 8 to 10 patients a day on average. So it's not, I guess, not having a significant impact in terms of the other attendances in ED, but is definitely very well received and welcomed.
And do you think that's as a consequence of the sort of soft launch that it's had, because it has had a fairly cautious launch so as not to overwhelm the capacity of the 111 service? Do you think that with a sort of further amount of publicity around it, that's going to start to impact differently?
Chair, could I?
Thanks, Carl.
I think the project team think that has had an impact. I think they would be really keen to start launching it, but are mindful that we've been asked, and we did escalate this to the national team. Given where we are with presentations at A&E, it'd be really good if we could ramp up the comms locally and regionally, and we're asked not to because of those concerns. We think also that we'd be able to offer more in terms of technical language, but in terms of front doors into the hospital, because at the minute it's A&E, but there are other ways into the hospital that we could utilise, and they're the things that we are starting to work up. And I think NHS Treble 1 will be even more pressured when the other catchments start to come on place. But it is definitely the right thing, and doing it in incremental ways, given that it's winter and in the middle of a second spike of the pandemic, doing it cautiously makes sense, I think.
Completely agree, Carl. Thank you.
Yes, Rebecca.
Absolutely. Go ahead, Ian.
Yes, I mean, I sense a slight sort of disappointment about the way this sort of, has taken off. Obviously, doing it in the middle of COVID is not helpful. I'm just wondering, though, given that there were a few pilots, have we had sort of contact with the other pilots to see if their experiences are the same, or whether they'd be more successful or done anything differently from us, just to help us as a guide for the future?
Yeah, I'll take that as well. I think it's been two ways. Blackpool went before us, so we were able to, and the project lead, the programme lead for that has been really pivotal, and also the commissioner for NHS Treble 1 services for Cheshire and Merseyside, pivotal in those connections, and then also not in terms of our learning, but also how we help others in terms of the governance, in terms of what some of the pitfalls might be that we weren't aware of and then stumble into. So definitely those connections are in place. And I spoke to Sarah. There's two SROs, Dan and from the Acute Trust and Sarah, and they are connected. And when I spoke to Sarah, she talks a lot about that's what a fair chunk of the work is communicating out what our experiences are so far.
Thank you.
Thank you. Any more comments, questions or observations on this, either from people who are online or on the phone?
Councillor Knowles, I think from our perspective as a provider of urgent care and having access to these appointments, I think this is something that will take some time to embed, and that will have significant benefits for the future. We've definitely not seen the capacity that we might have expected, but I think as time progresses, we'll see those appointments utilised in a better way, and we can stop the direction of patients to A&E in the system.
Certainly feels like a very positive step. It makes sense, doesn't it? But also that there's been an element of caution around making sure that it wasn't overwhelmed in its early days. It feels very much like something that we should revisit as Health and Wellbeing Board after a bit more time has passed, just to see how things are going and see what learning has been acquired in the process of the next bit of the rollout of it, particularly as it is likely to get more sophisticated with the sort of different routes into the hospital. So I think that might be something that we make sure stays on the work stream when we get to that item. If there aren't any more comments on that one, should we go on to the next item, which is the integrated care system? We're back to Simon on this.
Apologies, put up with me again. I need a bit of a run up to this one because it's ever changing, really. Integrated care systems aren't statutory as yet, and if I can just bring it forward in relation to different geographical footprints. So integration and NHS provision has to be done at least 4 geographical footprints. One's on a neighbourhood, which is delivered by and coordinated by primary care networks. So looking at integrated delivery models, the delivery of multidisciplinary teams and implementing of social prescribing. Then there's a entity called integrated care partnerships, which are place level, so borough level. So that's about developing new provider models, joining up council, hospital and community services, closer working as Warrington Together does with the VCS around prevention and population health management. Locally, we're also working on a mid-Mersey footprint, so that's our 3rd footprint. And then finally, as a lead into this paper, across Cheshire and Merseyside, there's a move to work across integrated care systems, consisting of populations of between 1 and 3 million. So that's about planning for the future, overseeing strategies, managing collective resources, sharing best practice and responsibility for performance and resolving challenges. That's the government's directions. And under the NHS long-term plan, all strategic transformational partnerships are expected to become ICSs by April next year. So that's the Cheshire and Merseyside Health and Care Partnership. The judgment as to whether an SDP becomes an ICS is largely dependent on how strong the relationships are between its member bodies, the 9 local authorities making up Cheshire and Merseyside Partnership, and how capable of joint decision making they are. The reasons for this is things we've talked about before around joining up population approaches, that the wider determinants of health are better tackled outside of the existing silos, and the integration of health and care has the potential to drive improvements in population health by reaching beyond the NHS to involve local authorities and other agencies to tackle that. But it's not a statutory body as yet. So I'm reading this because it changes every day. So what I've done there is the latest publication from the King's Fund Chair, which just talks about the existing 18 integrated care systems, of which Cheshire and Merseyside aren't one. So they're more developed in establishing the work of the ICSs, but also the components part both on a place-based level, which is integrated care partnerships, and on a neighbourhood basis. So I'm sure colleagues can help me out here in relation to what that means going forward, but there is a decision about the public consultation in relation to the potential establishment of an ICS across Cheshire and Merseyside, the particular impact around what that means for the CCG functions across Cheshire and Merseyside, and how we ensure that the existing capacity and resources discharged by the 9 CCGs across Cheshire and Merseyside are best placed within the place systems to tackle those wider determinants of health. So there's guidance on this. It's been put on ice really around COVID, but I hope scoping out just on very rudimentary terms around what an ICS is and the vanguards and the pilot sites will be helpful in terms of informing our discussion going forward. I'm sorry I can't be more helpful, Chair.
It's a huge topic and a short time scale, and I think that one of the words that jumps out from what you've just said for me is about consultation and making sure that certainly our business is looking after the interests of the people of Warrington and making sure that they have some meaningful information and consultation around this whole territory. And I suppose the larger the organisation, the further removed from the place it becomes. Within that, the whole question of the CCGs is a really important one, because we've gone from guidance that we should probably be looking at having a quarter of the number of CCGs as against where we started, to looking at them being sort of conflated even more, and looking at the potential for there being one sort of super CCG across the whole of the Cheshire and Mersey footprint, when we're in different places where we've got to on that, in different bits of that footprint anyway. So getting us to the point where some of that complexity can be communicated simply enough and straightforwardly enough for people to be meaningfully consulted on it is a key challenge, isn't it?
It is. I note that the 9 CCGs which merged across Sussex offered the public a 2-week consultation window. So I know Professor Broomhead has written to the Health and Care Partnership to ensure that we at least adhere to the Cabinet guidance in relation to consultation.
Is that something that this meeting feels it wants to make its views known on? I'll just throw that one out there for anybody to add their thoughts.
Yes, can I come in, Chair?
Of course. Go ahead, Councillor.
I think it's really important that we get some proper scrutiny on this, and that we're not, pushed into something that isn't going to work for us, or is not going to have the best solutions for us. And we really need to get a sense of what it means for Warrington across that whole footprint, and whether it's the right solution for us. Because it doesn't necessarily have to be that solution, and we need to just be sure that we're not being pushed into something that isn't going to work for Warrington. It's not going to work in our best interests. I
think that's a really helpful starting point. I don't know if anybody else has any thoughts or anything to contribute on this. There's a bit of a sense that the juggernaut is sort of set on course, but we do have the capacity to influence where it goes, don't we?
We do, yeah, definitely.
Councillor Knowles, Colin Scales has asked me to raise that he is the representative on the ICP network, which has been set up by the Healthcare Partnership, and I think some of this is really quite complicated and trying to understand how it does fit in, and I think he would like to bring a presentation, if possible, to maybe the next meeting of this board to give a bit more information about what's happening at the ICP level and his role as the Warrington system representative on that.
I think that we obviously need to look at this in considerable detail, and I think the problem is when the detail crystallises, isn't it? Because at the moment it seems to be changing all the time, doesn't it? So do we anticipate that by the time of our next meeting there'll be some clarity, or are we in danger of missing the moment?
I think.
Well, sorry, Sarah, go on.
I think Colin's suggestion is that the Healthcare Partnership has specifically asked that the health and wellbeing boards in each area are kept up to date. So I think whether we'll have a full picture or I think we'll have more clarity, and I think it would be useful to keep everybody sighted on what that looks like, recognising the importance of place and not missing out on opportunities. So I think it probably is. It feels like it might be beneficial.
Well, Chair, can I offer that rather than waiting to January, if there's any developments through my work with Sarah and Colin, we can send papers and updates to members in between meetings.
I think that's really helpful, Simon, because I think the concern is whether it's too long. Not that things won't be ready, but that we'll have missed an important moment when we ought to be feeding in. Even with the space between this meeting and the next one. I think if between you and Simon you can keep a very close eye on that and make sure that members of the board are kept informed, I think that would be very helpful.
Yeah, that's fine. I'll connect with Simon, and obviously Colin's got that information with the connection to that meeting.
Okay, and any other thoughts or contributions on that particular item? If not, I'll go on to the work programme, which was just to keep that under review. I don't know if there's anything in particular that that anybody feels that they need to incorporate.
Could I just mention, Chair, on behalf of Tara, that the board did ask for a report around the impact of COVID on Black, Asian and minority ethnic communities, yes, rather than waiting for a standing item. And I know she's very grateful for partners who have compiled that. We'll get that report ready to you before the next meeting and not wait to the next meeting to present it.
Again, that makes sense. I think we're in a fast-moving environment at the moment, and I think this board needs to be able to work in a more agile way when it needs to, if partners are agreed. Okay.
Comment, sorry. Thank you. It was just to say that it might be useful going forwards to have some updates in terms of the town deal programme, in terms of health and wellbeing aspects. I'm just conscious there'll be quite a considerable amount of work over the next 12 months, and it might be useful to bring updates to this board.
I think that also makes a lot of sense, and we've spoken, Lucy and I, in other meetings on how pleased we are to see those health and wellbeing elements within our town deal. I think that the town deal, it has to make for sort of good economics, but it has to be good for people as well. And we've got some schemes there that are quite powerful on both fronts, haven't we? So keeping a close eye on those and helping to sort of shape and craft those as they go forward will be really useful, won't it?
Definitely, thank you.
Anything else to add? If not, I'm going to close part 1 of the meeting and we'll go on to our very interesting part 2.
Thank you, Chair. Thanks for stepping in.
Yes, Sam?
Just say thank you, Chair, and thanks for stepping in.
And I must apologise profoundly for my own rather strange internet connection. We're just not having the best of days between us, are we? But we'll close the live element now, thank you, and we'll go on to part 2.
Chair, it's Jenny from Democratic Services. Could IT just confirm that the live feed has ceased?
It's saying that it's ended now.
Bear with me 1 second, it should just go on there.